So now I'm really privileged to welcome James M. Perrin, who's professor of pediatrics at Harvard Medical School and director of the Division of General Pediatrics and the Massachusetts General Hospital, the MGH Center for Child and Adolescent Health Policy, which is a research and training center with an active fellowship program in general pediatrics. He's also vice chair of the Department of Pediatrics for Research at Mass General, and a noted expert on measuring quality in pediatric care. His research has examined asthma, middle ear disease, children's hospitalization rates, health insurance, childhood chronic illnesses and disabilities, and the interactions between those components. There has been throughout an emphasis on quality of life and quality of care. Dr. Perrin has served on numerous Institute of Medicine committees related to maternal and child care. And so, Jim, we're really thrilled to welcome you to Princeton to talk on improving the health of children in New Jersey. Thank you. So I'm not going to mic you because I think it's okay.
Sounds great. Dan, thanks very much. It's really great to be here, and it's fabulous to be in a group that is really interested in bringing about change in the health and health care of children in this state. I will put a couple of disclaimers here. I don't know anything about New Jersey except what some of my best friends tell me about New Jersey. I have worked for many, many years with a sociologist who got her undergraduate training here and was very much turned on to population studies as a result of her undergraduate work at Princeton. And she has been a fabulous partner for many years, and we've done lots of interesting stuff together, some of which I will share with you today. Let me just see, what do I do for the slides? Yeah, there we go, great, super, thanks. I can do it easier than that, I'm sure, right, good. So the key themes in my talk are going to be some issues in improving health of children and youth, a little bit of discussion about why we should be investing in children anyway, why children's health differs in critical ways from those in adult care. And let me spend a couple of minutes on these two issues as we move forward. I think we all talk about investing in child health for some of the reasons that Nancy suggested earlier, which is if we could prevent very low birth weight, we could cut down on expenditures. If we could do some prevention, we could cut down on expenditures. And much of the argument has really been on the expenditure side for improving child health. And I certainly support that logic. It's incredibly important that we think along those lines. But let me lay out some other reasons for investing in child health. I have a feeling Renee talked about them earlier, and I'm sorry I missed her talk, but they are obviously in getting young people healthy to enter the school system at age 5 and to be able to participate effectively at that level. And that will help us produce a much stronger workforce 15 or 20 years from now. And you know how many companies think with a 15 or 20-year objective, or how many Congress people think that, which is, of course, this. But let me sort of lay out still one other reason for investing in child health, which is 1 in 5 workers in the American workforce today have a child with a chronic health condition. Larger numbers, of course, than 1 in 5 have a child without a special health care need in the workforce. That really has changed, of course, dramatically from the First World War. You know, women entered the workforce predominantly after the First World War, but most of the women who entered the workforce, of course, were unmarried at that time. And it was after the Second World War and really in the 50s and 60s that women with children tended to enter the workforce dramatically, and that changed the workplace in many ways. But most importantly, I think what good companies are realizing today is that in order for their employees to be able to produce widgets in the right numbers, or to be actually effectively present at the job, they don't need to be worrying about their children. And we know that if you have a child with substance abuse, or if you have a child with ADHD, or a child with depression, or a child with some other condition like asthma, which can exacerbate, then the likelihood that you're actually going to be present on the job, doing your job right, goes down. And America's employers are recognizing that investing in children will actually help them be far more productive in the workforce, their parents being far more productive. Now, as I mentioned that children's health care differs in some critical ways from that of adult health care. One is the tremendous emphasis on prevention. I know Renee talked about that. Second is the developmental framework in which kids grow up. Now, I kind of think adults develop too, a little bit. But in the developmental aspects of child health are really quite extraordinary. If you think about dealing with a 1-year-old or a 1-week-old and a 15-year-old as just a couple of examples. The second or third is really the continuing dependence on adults, not only parents, but the wider adult system of care that I'm going to talk about in a few minutes, and the complex system of providers that children face that do indeed include a lot of health care, for example, in the public education network, and we don't coordinate that very well. Another area I'm going to spend some time on is the changing epidemiology of chronic conditions in children. And even though I agree with Nancy that VLBW, very low birth weight, is a cause there are other major problems that just swamp out VLBW. And the third thing I'm going to spend a little time, fourth thing I'm going to spend a little time on is really developing teams in healthcare and the implications for that for reorganizing services. Now, I think Dan asked me to come because he read my editorial in the New England Journal a year ago, where we commented on a very dramatic study by Rita Manjones-Smith and her colleagues, mainly from RAND. And basically, they demonstrated that just as with adults, kids are getting about half the care they should be getting. It was in acute care, they were getting about 2/3, in chronic care about a half, and in preventive services, somewhat to our surprise, only 41%, at least by their measures. Some particular examples, about less than half of children with asthma receive anti-inflammatory medications. Only half of children age 2 are fully immunized. 16% of children 0 to 3 years old with high fevers had their urines checked for infection. 42% of sexually active adolescent girls were checked for chlamydia. These are not good numbers. They're not ones we want to say are really exciting and wonderful examples of the quality of care we're providing. So even in these realms, we can do better, and we need change. But there's important things that are very relevant to this audience that weren't examined in the Manjones-Smith study. It focused on office-based care, a very narrow piece of child health care and well-being. Kids receive care in many venues. I mentioned the school system, but there are a number of other venues in which children receive health care. The study was really limited to the written record, and those of you who are clinical practitioners know how well the written record really represents what you do in the office. There was very limited attention to other critical aspects of pediatric care, such as developmental surveillance, such as the coordination of services, especially for children with chronic conditions, such as the identification of developmental and behavioral risks and conditions, or the counseling to improve health and health behaviors. And there was no assessment, basically, of family and community issues, making it very difficult to figure out what these numbers mean in the broader context of how children grow up and the kind of health care that they get. So I think these are bad numbers. I'd love to have numbers in these areas as well. I'll share some of the ones that we have from other research that we've done, but my expectation is that the 50% or 46% may be just about a tip of the iceberg of a much broader problem in children's health care. Other elements that were missed were some of the elements that are in the Commonwealth Fund Child Health System Performance Report, including measures of equity and access. They simply weren't in that study at all. And some of the other indicators of quality that you've already discussed today, such as having a medical home or appropriate access to subspecialty services. Now, in framing what we do with children and the ways that we have some influence on children's health, I think we need to talk a bit about the broad community of services. And the next slide will be a little bit overwhelming, but I'm still going to show it to you, which is if you think about where children get support that affects their growth and well-being, it really comes from a huge variety of sources. Now, this happens to be a slide from a paper of ours talking about system of care for children with chronic conditions or special health care needs, but quite frankly, this is highly generalizable to all children. And if you see up there, we talk in pediatrics about the medical home. Indeed, that's one piece of it, but it's one piece of many others. So the mental health care system, social services, education, vocational services, housing. So you can't think about a child with asthma without thinking about her housing. Public health services, public safety, juvenile justice. An awful lot of children with chronic diseases, especially with mental health disorders, are in the juvenile justice system. Transportation, insurance financing. And of course, in that sort of close to inner circle, the series of community supports such as spiritual resources, recreational programs, voluntary organizations, informal supports and services are all highly relevant to how families do, to how families in Newark do who live in more cohesive neighborhoods versus families in Newark who live in less cohesive neighborhoods, as just some examples. And this is really the complex system, and we may have small points of light in one of these quadrants, or I don't know what you call these small little pie pieces. You may see one point of light here and there, but in fact, it's a much broader system that influences children's health and well-being. And I would speculate that this is broader in many respects than the issues that affect the health of adults, young adults, and old adults as well, although many of these things are applicable as well. So if we want to improve child health, we need to think about the community of services and how these interact effectively to help children. Now, a couple of other things that were not covered in the Mann-Jones-Smith report were less common but potentially more serious conditions. So, for example, follow-up of very low birth weight infants was essentially totally off the table in that particular study. Yet that's a very important point if we're going to try to improve outcomes for that population and to cut down on costs. So our own work has documented very limited use of subspecialists by children with chronic conditions, both among Medicaid-insured children. I'm going to show you those data in just a minute. We thought this was really, by the way, only a Medicaid problem, that it was a matter that those cardiologists at Specialty Center A just weren't willing to see children who were insured by Medicaid, but were willing to see children in the privately insured market. In fact, that isn't true. There's a huge, we think, gap in the use of subspecialty services by children with chronic conditions, regardless of whether they have public or private insurance. Karen Kuhlthau, just to give her credit, is indeed the sociologist I worked with who had her early imprinting experiences here at Princeton. The other area that was missed and is relevant, I think, to thinking about long-term issues for health for children is the tremendous epidemics of chronic conditions among children and youth. And I'm going to again spend a little more time on that, but when I grew up as a young doctor, we sort of assumed chronic disease just hardly existed, wasn't a big thing for children. We needed to train primary care physicians to be really comfortable dealing with anticipatory guidance, well child care, acute illness, but chronic disease was just not a big player. Life has changed. So these are our data from Medicaid populations, where we looked at a whole series of chronic conditions, the ones listed on the left, varying from diabetes to sickle cell disease to arthritis to cerebral palsy to congenital heart disease. And this is not worth going into much detail except to make the point that almost all of these children did indeed see a general physician in the year of study that we happened to choose. We actually did some sensitivity analyses to see if it made a difference to go to 2 years or 3 years, and it doesn't. But basically 80 to 90% of these children saw a primary care physician during this year. We don't know how good the quality of that care was, but it actually occurred, which flies in the face of the sort of worry by primary care physicians that they will lose their children with chronic diseases if they send them off to subspecialists. In fact, they're going to continue to see them, and there's some evidence to think they're going to see them more and more. Now, the more worrisome slide is really this. And this is looking at the percent of children insured by Medicaid who saw a subspecialist in the previous year. And again, we did sensitivity analyses and found it's pretty much the same if you go to 2 years as well. And what's striking is that with the exception of a couple of conditions like congenital heart disease, spina bifida, and seizure disorder, essentially fewer than half of these children had seen any relevant subspecialist in the previous year. Most of them did not see a subspecialist. You can look at this. Kids with sickle cell disease, only about 35%, 1 in 3, had seen a subspecialist that had anything to do with sickle cell disease. ADHD, asthma, diabetes, low. Hemophilia, relatively low. Hemophilia is a pretty rare disease. And as a primary care physician, I sure as heck wouldn't want to be following a child with hemophilia without knowing that there was someone backing me up and knowing what's going on with this particular condition. These data, I think, frankly, indicate a tremendous gap in access of America's children with chronic diseases to appropriate services. Now, we tried our best, this wasn't easy to do, to separate whether these were likely pediatric subspecialists versus adult subspecialists. The adult rheumatologist who's seen a child with juvenile rheumatoid arthritis. And in general, what we found is about 50% of the visits were to pediatrically indicated subspecialists, and the other half of these subspecialty visits were to non-specific subspecialists, probably adult subspecialists. The only major exception was for congenital heart disease. Even there, of course, only about half of these children saw any subspecialist. Now, as I said before, we thought this was a Medicaid problem. But the reality is, looking at national survey data, we found this was a general problem. And it's just worth looking at this sort of first column here with chronic condition and noting that children with private insurance, about 28% of those children, very similar to our last slide, had seen any kind of relevant subspecialist for her chronic condition in the previous year. Children with Medicaid, these are not really significantly, importantly different numbers, 26%. But children without insurance, and you have 10% of that or so in New Jersey, had much lower rates of seeing a relative subspecialist than children with any kind of insurance. So it's a major gap. It's a problem for children in general, not just those with Medicaid insurance, and it's particularly pungent for children without any insurance. Let me move on now and talk more about what's happening in the broader issue of chronic disease among children. The most striking thing is a huge increase in numbers of children with chronic diseases in the last 3 or 4 decades. These are data from Paul Newacek. There are several other data sources which say monotonously the same thing. That in 1960, approximately 1.8% of children were reported by their parents as having a chronic disease that was serious enough to limit their daily activities. By the mid-1990s, this is about 7.25%, and today it's about 8%, i.e. a quadrupling of the number of children with activity limitations due to a chronic illness from 1960 to today. That's a huge increase. Why is this increase taking place? Let me give you some examples of the epidemics, and you've already heard this a little bit here today. Overweight is about 11.25 million children in the United States today. Asthma, which we thought was peaking a decade ago, continues to rise. 5 million children in the United States, 4 million children with ADHD, 3.5 million children with depression, 500,000 with autism spectrum disorders. Now, just to put it in perspective, this is about 80 to 90 million children in the United States. So 11 million out of 80 million is a huge percentage of children with obesity. I should have changed that term because the CDC has reframed the terminology, so what I call overweight should be actually called obesity in this slide. These are massive, huge numbers of America's kids. So why? So the growth in rates of chronic conditions from about 1960 to 1980 in many ways represented improvements in survival. Those children with leukemia who died when I was an intern now have very high rates of survival. We have much better interventions for children with cyanotic congenital heart disease. Children with cystic fibrosis who had an LD50 of 5 years of age when I was a young doctor now have an average life expectancy in the high 30s. So huge improvements in survival occurred from 60 to 80. Our estimates were from a variety of data is, however, that by 1980 we'd already achieved approximately 80% of the achievable survival in children with serious chronic diseases, and almost all of the increase in rates of chronic disease among children since 1980 represent the new epidemics of common chronic conditions, basically obesity, asthma, and children's mental health conditions. There is some impact of very low birth weight. We don't know an awful lot really about long-term follow-up of children who are exposed in utero to potentially dangerous toxins. And AIDS, even though it didn't occur in 1960, we think, only covers fewer than children in the 5-digit numbers in this country, so way lower than the numbers I presented a few moments ago. So indeed, we've done a wonderful job, but it's gotten worse in the sense of these new epidemics in the last 25 years. The long-term implications, by the way, for you folks in New Jersey and for all of us in this country is that we're going to have major public health burdens from rising cardiovascular disease, from obesity and type 2 diabetes, increasing rates of pulmonary disability from asthma. We already know those rates are actually increasing in adolescents today. And we're going to have higher rates of mental health conditions, which will, all three of these really, decrease workforce participation by young adults, people in their 20s and 30s. It will decrease their quality of life, and it will increase their reliability on disability programs and other kinds of public support. And we are totally unprepared. We have done nothing whatsoever in the public sector to prepare for these dramatic new epidemics that are going to hit us in the next decade. We're not talking about 20 or 30 years from now. We're talking about now. So just examples. Obesity, using the term for 95th percentile, went from about 6% in the early 1980s to about 15% in the mid-1990s. Extreme obesity quadrupled from 1% to 4% during this period of time. Asthma has basically doubled during this time. ADHD, the hardest one to measure carefully, I realize, has probably doubled as well in prevalence. So parallel developments have led to these dramatic increases in childhood chronic conditions. One really is amazing biomedical advances. Children with chronic conditions do live longer. More children survive, indeed. But it's been associated with regressive social changes. That's my terminology. Let me give you a couple of examples of things in a moment. We do know that there are increasing rates of VLBW. It probably relates a little bit to those increasing numbers. We know that poverty is associated with higher rates of essentially, but not quite, all chronic diseases. And we know that poverty is associated with increasing severity of many conditions. But there's actually very little evidence of changing rates of poverty among children over the last 40 years. It's been bad, and it's stayed bad. We've improved poverty rates dramatically among the elderly, associated temporarily with the onset of Medicare. But Medicaid has not done a lot to improve the economic status of young Americans, and kids remain painfully poor in this country. What other changes in children's lives? Well, genetics have been associated with all of those conditions, with asthma, with obesity, with kids' mental health conditions. But it's hard to postulate genetic drift alone, changing basically genetic pool of parents in this country. Obviously, many of these conditions have genetic risk combined with environmental triggers. There's been a lot of work on changing physical environments and the cleanliness hypothesis as an explanation for the growing rates of asthma. I don't want to go into too much detail on those, but rather focus on some other things that I think are relevant to public policy and how we try to change the social environment for children. And they are parental stress and availability has changed substantially. So children are spending far more time without adults or with a wide variety of adults trying to help them find their way through, among other things, television and media, which has expanded tremendously. It's the most unstructured and uncontrolled social experiment in our society, the tremendous growth of television, which kids, as you know, typically sit in front of and press buttons frequently and have about a 30-second frame for each channel that they're watching. Children's social environments have led to substantially decreased physical activity for a variety of reasons. There's less physical activity in schools, especially in poorer schools. Kids are kept inside because both perceived and actual risks to going outside. There's more time spent indoors and sedentary when they're indoors, so we know that obesity is highly associated with sitting on your couch and watching that television and eating the dancing Doritos while you're in front of the television. We also know that for poor kids especially, cockroaches and cockroach infestations are associated with asthma, and although I don't know of any data that suggests that there's an increasing rate of cockroaches in Newark, a higher population of cockroaches, we do know that children in Newark and other inner city settings are spending far more time indoors in intimate relationships with their family cockroaches. We also know that diet has changed a lot. These are huge changes in children's social environment, and we can link obesity, asthma, and mental health conditions back to all of these changes. So if we're going to prevent them, which we really need to do, we're going to need to think about all of these issues. All right. One other thing in the changing epidemiology is the growth, the crisis in children's mental health, the tremendous growth in rates of many conditions, ADHD, depression, autism, conduct disorders, etc. We know that there's absolutely inadequate financing of children's mental health services. Where it is, it tends to be for the really severely emotionally disturbed child. Gets a lot of attention in the press when something horrible happens. But we've had very little attention to prevention and early identification in the mental health sector. And with the changing financial environment, a huge increased demand on primary care to provide mental health services. Some new models that are relevant as we try to plan organizing care, and I'm going to go into organization of care as we get closer to the end of this talk. One is really the co-location of mental health providers in primary care as a way of improving the care children can get. There are also educational and consultation models. We've had in Massachusetts a program by which primary care providers can link with one of 7 teams around the state. And if I have a question about the SSRI that I have this teenager on and I'm worried about it, I can get a consultation from a psychiatrist within, believe it or not, half an hour. That's the rule, and it's actually met in our system. And about 12 states are now trying to develop similar models of backup care, letting us in primary care actually develop some confidence in what we're doing better. But I think that the models of mental health care should not be based on the notion that primary doctors can do it all. It's going to have to be based on the notion of developing teamwork. And I'm going to go on to teamwork in a few minutes in a bit more detail. I might say that the Academy's Task Force on Mental Health has been very actively pursuing a series of these questions: how to improve the financing, how to improve the organization of services for children with mental health conditions. Now, effecting change, improving child health, will require systematic efforts among payers, providers, and patients, and obviously their families, especially for children. I think some of the elements are going to be requiring some focus in chronic condition care and prevention, high-quality information technology and transparency, which we do mainly by 1,000 points of light strategy in this country today, rather than a more coordinated, comprehensive fashion, family-centered care, and aligning financial incentives with quality. I think there are some very exciting new organizational models. Many, in fact, I would say more and more, most health concerns of children and youth don't fit a model of physician care alone. So you can work on improving Medicaid coverage and SCHIP coverage. You can work on improving kids' access in a variety of ways. But we need to be thinking about the other side of that, which is what do they get access to that might really improve the outcomes that we're after for children. So chronic disease and its complex multidisciplinary management doesn't fit the primary care physician in her office model very well. Mental health conditions, a subset of chronic disease in childhood, doesn't fit the physician-only kind of notion. Preventive mental health services, really helping families nurture their kids effectively, the kinds of things that Nancy and Sarah were talking about in different ways, doesn't fit the notion of primary care alone, and the integration with community services, WIC, housing, recreation, etc. You know, primary care physicians know that nutrition is important, but they have relatively little idea about how to even fill out a WIC form. And other people can do that vastly better than primary care. So each of these calls for a new theme of teams rather than the notion of 3 or 4 pediatricians working by themselves. Medical home, I don't know if Renee talked about medical home earlier. There are some definitions and character examples of medical home that you probably have heard of. Some of the characteristics of the chronic disease model that go into the medical home include registries of children who meet some definition of chronic disease, some monitoring of them using standards of care for those conditions where they exist, significant amount of parent and patient involvement, education of kids and parents about their disease and about their prevention, all in the context of comprehensive and coordinated care. These are some of the characteristics that we want in the medical home. And I'd venture again here too, we need to talk about partnerships, teamwork, rather than relying on well-trained individual physicians alone. Now, we recently published a review of the literature on medical home a couple of weeks ago in Pediatrics, where we systematically reviewed what literature existed. I must say we went into this with some fear and trepidation, because our fear was we would find lots of great examples and no good data. The reality is actually there are some good data. And we were able to document that although there's no good study of medical home as a whole, incorporating all of these concepts together, that a number of the elements of medical home are clearly associated, including in randomized controlled trials, with improved family-centered care, with effective care, kids getting the kinds of care they should get. That really means essentially the work in the Mann-Jones-Smith et al. Article that I started with. Timely care, getting care when they needed it, improved health status, most of the studies here are among children with asthma, by the way, and better family functioning. These are all outcomes that are good, and they are associated with the medical home. So we can do it, and we ought to do it better. So, in summary, let me just make the recommendations that programs and policies nationally and here in New Jersey must build on prevention. If we don't deal with prevention, these epidemics of quite severe chronic diseases are going to simply swamp our investments in ways that are going to be quite dramatic over the next relatively short period of time. Got to recognize the importance of chronic conditions, and I use a broad definition there because I certainly include mental health conditions. We need a developmental approach, and we need to have a central role for families. So what are some of the programs that are worth working on? Teamwork, really building models of team care in all of our settings, from primary care, by the way, up to subspecialty care. To integrate that teamwork effectively with an organized system of community services. To think again that it's just those of us working in our offices and not having some kind of connections with the broad range of services that the children we work with make use of and need. We need to change the incentives to do the right thing. And without going into too much detail, what I really mean here is we need to pay clinicians to do the things that they're best able to do and to provide them the time to do it right. So a decade or so ago, I chaired the Academy's committee writing practice guidelines for the management of attention deficit hyperactivity disorder in primary care. And we said a couple things there. One is you got to be specific and spend some time gathering data both from parents and from schools. It takes time to do it, and you can't do it if no one's paying you to do it. That's just one example of where we need to change the incentives so that physicians and their colleagues in these new teams can do it better. Got to assure access, and you got to support families. Thank you very much.
Thank you for your talk. The question, teams seems to be the topic of the day. Renee brought up teams and reaching across silos. And
Thank you. Great.
So, and I think that is key to us really having a comprehensive care for children. It's easy to do in a hospital where you can sit down, multidisciplinary setting, talk to the different specialists, but it's very difficult, as you know, as a private practitioner, when I have a chronically ill patient that sees a host of subspecialists, and you get reports from the pulmonologist and the endocrinologist. Really, do you have any ideas of how you implement the team approach in a private practice setting?
Yes, absolutely, and that's a great question, and we're struggling to do it right. So there are a couple of things that are going on. One is, I'm going to focus for a moment on mental health conditions, where there has been some good experimentation with getting mental health professionals. I'm not talking about child psychiatrists necessarily, by the way. Mental health professionals sharing an office or renting space or being next door. So it means that if you have a depressed mother coming into the office and it's pretty clear that she's having troubles, you don't need to say to her, basically, boy, I can give you the name of someone to call, and they'll get you an appointment 3 weeks from now, 15 miles from here, which used to be the strategy, right? It means now that those primary care docs can send that child right then to that mental health professional and get some interventions started right now. And there are models for how to pay for that we're working on. The task force will be documenting that and give you some ideas on how to do that. I think the second thing, for these kids with complex chronic diseases, the primary care doc spends a tremendous amount of time, which isn't inexpensive, working on these patients. And their teamwork, at the very least, of a really good nurse can be incredibly effective and cut down on physician time substantially and make it actually a financially viable arrangement for the office. So at that level, I think that's very useful. I mean, optimally, even in the primary care sector, it would be great to have that really good office nurse who's your partner in dealing with these children with asthma or dealing with these children who've seen the orthopedist and everything else. Also be someone who's a nuts and bolts person who sort of knows how to get moms and dads access to WIC, better housing, and other things. There are ways of paying for it. We have to incentivize it better.